record. So I'll start with introductions first. For those who don't know me, Osama Musa, I'm based in London, UK. I trained in general and upper GI bariatric surgery in the north of England and the northwest of London for my higher surgical training. I also did my postgraduate research degree in metabolic health at Imperial College London. And I'm currently at the start of my bariatric surgical consultant career. We've set up this bariatric TUGS group with the great support of my friend and colleague, Kamal Mahawar. We have also regional representation from around the globe, from every continent. As I mentioned, this will be a monthly event, and we aim to bring to you a multidisciplinary aspect of bariatric and metabolic surgery. Of course, everyone knows my good friend and colleague, Professor Kamal Mahawar. He's a leading academic and a very well-established bariatric surgeon in one of the biggest bariatric centers in the UK, up in the north of England. No doubt we all owe him, and we wouldn't be here today if it wasn't for him co-founding and chief coordinating the TUGS community. And more importantly, a very big special thanks to our outstanding speakers for agreeing to join us today and enlighten us on mental health. Can I just mention that unfortunately Dr. Paul Davidson had to apologize because of an emergency, and we wish him well. The title of today's meeting is The Role of Psychologists for Patients Seeking Bariatric and Metabolic Surgery. We will start with Dr. Stephanie Sogg. She's on the importance of bariatric psychologists, and are they the gatekeepers of bariatric surgery? Stephanie, allow me to introduce you. She's a clinical psychologist and an assistant professor of psychology at Harvard Medical School. She has treated patients at the Massachusetts General Hospital Weight Center since 2003. Dr. Sogg also conducts research on obesity and bariatric surgery quite regularly, and specifically the intersection between obesity, bariatric surgery, and addiction. She is an author of the Boston Interview for Bariatric Surgery and the official ASMBS recommendations for the pre-surgical psychosocial evaluation of bariatric surgery patients. She's the past chair of the ASMBS Integrated Health Clinical Issue Committee, and she served two members at large at the ASMBS Integrated Health Executive Council. So without further ado, Dr. Sogg, the floor is all yours. I think you're muted, Stephanie.
Okay, I'm now unmuted. Okay. Well, first of all, I want to just say thank you to the TUGS organization for inviting me, and I feel especially honored seeing who my fellow presenters are. And I'm going to dive right in. And because the question here is about gatekeeping, I'm going to start out with a focus on the psychological evaluation, because that's obviously the most relevant to the question of gatekeeping, but I'm going to move beyond that later in my talk. So I think the inherent in the title of my talk, which was assigned to me, is a fundamental question, which is, why do we do the psychological evaluation in bariatric surgery? Or to put it in more American lingo, what for? And as a way of answering that question, I thought it would be good to start by talking a little bit about what this evaluation is not for. And it's not best conceptualized, and certainly we should not be presenting it to our patients as a hurdle or because we think the patient is crazy. So it's important here to point out that psychology input is helpful really across medical domains, whether patients have psychiatric disorders or not. And I know that within the NHS, psychologists have involvement in myriad areas such as HIV, fertility, cardiology, stroke, many different places. So not just where we think patients may have psychiatric problems. And then there's another question here, which is, I know that in the States we grapple with this. Do we do a psychology evaluation for all of our patients or just some of them? And if we're only doing it for some of them, how do we determine which ones we're going to do these evaluations for? And I'm going to really argue strongly that this pre-surgical psychological evaluation is not just for people with psychiatric symptoms or diagnoses. And I'm going to come back to that in a moment, but I also think it's very important to stress that the psychological evaluation does not function as a crystal ball. And I think we really need to be honest here and acknowledge that the state of the art of the psychosocial research on weight loss surgery is still evolving. And so far, there's no single pre-surgical psychosocial factor, behavior, characteristic, meaning things that we might identify in that pre-op evaluation, that has been found to be a strong and consistent predictor either of weight loss or of psychosocial outcomes after surgery. And this probably has to do with the methodological limitations of the studies that have been done, and not an indication that psychological factors don't matter. But the fact still is remaining here that we can't tell for absolute certain, based on one or even a few simple psychosocial factors, exactly how someone's going to do after surgery. So it would be absolutely fair of you to ask, in light of this, why do we bother to do this evaluation? And I'm going to start my answer to that by pointing out that, in fact, there's very little research out there that has identified any preoperative factor, psychosocial or not, that's a strong and consistent predictor of surgery outcomes. And in fact, basically the only factors that we've found to consistently predict weight loss are initial BMI, age, and gender. And then there are very few medical factors that might predict a higher risk of certain kinds of complications. But that doesn't stop us from doing a thorough medical evaluation before the surgery. And what we do in the medical realm is that when we identify risk factors for poor outcome or complications, so as an example, let's say we have a patient who's at elevated risk for blood clots, we don't just not do surgery on them, right? And we also certainly don't just ignore the risks and go ahead and do surgery and hope that it's all going to turn out okay. No, we don't do that, of course. We develop a management strategy to try to minimize or avoid those risks. So for our patient who has an elevated risk of blood clots, we develop an anticoagulation plan. And that's exactly the approach that I think is the most appropriately and productively applied when thinking about the psychological evaluation for surgery as well. The most important two roles of the psychological evaluation really are, first of all, to identify any psychosocial factors that might affect the outcome of surgery. And sometimes, yes, this is going to involve clear psychiatric problems, but often we're identifying psychosocial factors that aren't formal psychiatric problems, but they represent potential challenges to good outcomes after surgery. So somebody who has a really hard time prioritizing their self-care, or they have deficits in their organizational or problem-solving skills that's going to interfere with adherence. So we are not just focusing on psychiatric symptoms here. We're going way beyond that. And I also think it's good to pause here and clarify what we're talking about when we say surgical outcomes, because although weight loss is the most obvious and measurable outcome of surgery, and it's also relatively simple to quantify improvement in medical comorbidities, those are not the only important outcomes. Psychosocial outcomes are also really important, and they're especially important to our patients, because ultimately, the most important thing from the patient's perspective is my life better now than it was before surgery? And we also know that independently of weight loss and medical outcomes, some patients have severe psychosocial complications after surgery. And I'm guessing that both of my colleagues are going to be talking about this in their talks. But we do absolutely see things like addictions, eating disorder symptoms, and even suicide. And obviously, we want to try to make sure that those things don't happen. So the other primary goal of the assessment is to enable the psychologist to formulate practical, specific, actionable recommendations to enhance the outcome after surgery. So for a patient whose depression is so severe that it is getting in the way of self-care, we might recommend that they get treated for depression, or that someone does some work on maladaptive eating habits, things like that. So I think that if you are asking your team's psychologist to simply say whether or not a particular patient should have surgery. In other words, if you're asking them to be a gatekeeper, you're really not making the best or the most appropriate use of that provider or the evaluation. So here's the answer to that question in the title of my talk: whether bariatric psychologists are gatekeepers for surgery. The point of this evaluation is not at all to limit access to surgery. On the contrary, it's the job of the bariatric psychologist to improve access by not just identifying, but also addressing psychosocial issues so that surgeons can operate on more patients and see better outcomes. Now, so far in this discussion, I've really been focusing on the patient as being the primary beneficiary of the team's psychologist. And I think that's a really narrow view. And I'm going to encourage everybody to broaden your thinking about this, because something that people may not always be aware of is that the other direct beneficiaries of having a psychologist on your team are the rest of the team and the entire bariatric practice as a whole. So right now, what I'd like to do is very, very briefly, those attendees who are not psychologists, I want you to think for just a moment about what your worst pet peeves are about patient hassles or challenging behaviors on the parts of patients. And just think about how much of your time are you spending dealing with patient issues that really are more psychosocial in nature and they're not specifically part of your job. Think about that for a moment or two. And I'm going to suggest that the team's psychologist is in a position to fulfill a number of functions that directly help the other members of the practice, including, by the way, your admin staff. And one of the biggest things that we can do for the team is to relieve the burden of dealing with all of that psychosocial stuff. In the US, I don't know if you had this in the UK, but many, many years ago, we had this old advertising campaign for a bathroom cleaner. And it had what they called scrubbing bubbles, which meant you just sprayed it on and the bubbles did all the work themselves. And the slogan for this cleaner was, "We work hard so you don't have to." And they would yell that as they were all going down the drain. Well, if I had to come up with a slogan for bariatric psychologists for an ad campaign, that slogan would be, "We handle the messy psychological stuff so that you don't have to." And one of the most valuable things that your psychologist can do is to suggest management strategies for difficult patients. And this might include patients who have psychiatric symptoms or eating disorder symptoms. We are the members of the team who can do this most effectively. And another thing I know that our clinic staff and providers do struggle with is patients who have really high anxiety. And understandably, patients who are really anxious are calling up, or they're sending messages through their medical gateway, they're asking repetitive questions, they're seeking reassurance, and this can be a drain on clinic resources. It can also interfere with their relationships with the other providers. So the team's psychologist can help with this by helping the team to set effective limits, or even just take on the job of dealing with the patient's anxiety directly so it doesn't overflow and cause headaches for the rest of the team. Now, one thing that I hear all the time from non-psychologists in our field is this buzzword that people have learned, and they may not know exactly what it means, but it strikes terror into their hearts, which is borderline personality disorder. Anybody familiar with that phrase? Patients who have borderline personality disorder can, in fact, be difficult to manage, and they can create difficulties for the clinic and clinic staff. So the team psychologist can help the team to come up with specific strategies to head up disruptive behaviors and create boundaries, and also present splitting, which generally means, it basically means that patients are causing discord between team members. We're also the most appropriate team member to take on the role of monitoring the patient's psychiatric functioning, both, of course, to determine when the patient's ready for surgery, But this is also now bringing up a really important point about post-operative psych involvement, because if we know that psychology support is available to the patient after surgery, it actually serves to increase access to surgery for patients who otherwise might be too vulnerable to proceed with surgery. And just as an example of this, at our practice, because we do have very comprehensive psychology monitoring and input available both before and after surgery, we feel comfortable operating on patients who other centers would not touch for psychiatric reasons. Best of all, if you let us, we can help make your program look good, because psychological support can contribute to improving patient satisfaction and outcomes and help to make sure that patients are ready for surgery, minimizing the risk of those psychosocial adverse events that I mentioned before. So hopefully up to this point, I've been successful in demonstrating to you that having a psychologist on your team really, it allows that person to perform a lot of important functions, both for your patient and the team. And I'm guessing that all of you are getting very excited about these benefits. And in fact, you may be asking yourself, wow, what else can our psychologists do for us? And there's several things. I'm going to touch on a few of them here. One thing that we can do is to educate the other team members about the role of psychosocial factors in weight loss surgery and the impact of surgery on psychological functioning, and also educating other team members about what kinds of issues to be looking out for after surgery and when should you refer a patient back to the psychologist. Non-psychologists, how do you know, those of you who are listening, how do you know when a post-op patient needs to see your psychologist? What are the specific signs that you're looking for? Maybe you're not sure. And by the same token, if there are any psychologists who are listening, how often do you sit across from a patient who's been referred to you after surgery and you're thinking, oh my gosh, why wasn't this patient referred back to me earlier? Or by the same token, why was this patient sent to me because their issues don't seem to be psychological? Your team psychologist can educate the rest of the team about what the important things are to be looking for and when and how to refer them. Also, by virtue of the training we have, the team psychologist is particularly well suited to help develop patient education and curriculum materials for pre-op education, post-op support groups. We can also help to establish policies for the practice regarding potential psychosocial contraindications, smoking, substance use, suicidality, intellectual impairment. We also can be doing outreach to other services, doing sensitivity training to reduce weight stigma among the other providers that are seeing our patients. I know in the UK, unless this has changed, that the bariatric service only retains patients for 2 years after surgery. So we really need to be reaching out to other services about what kinds of psychosocial factors to be monitoring for in the long term after surgery. And of course, psychologists are also specially trained to be able to assist with your program's research and program evaluation needs. We can help with study design, choosing research instruments, tools like questionnaires and surveys, etc. All right, so we've talked a lot so far about what your psychologist can do for you. And in the spirit of fairness, I'm also just going to cover what you can do for your team's psychologist. First of all, really importantly, loop them in on communication and involve them in treatment planning. Remember that psychology input may be instrumental in making sure that the patient is stable and supported enough to have the surgery and to do well afterward. Also, please give us lots of opportunities to learn as much as possible about all domains related to surgery, not just the psychosocial ones. Teach us things, explain terminology to us, give us articles to read, and support us going to trainings or courses so that we can do our jobs even better. Also, know about what they do and why they do it, which hopefully this talk has gone some ways in doing that, so that you really understand what we're good for. And then what we really want you to do is to put us to work. Use us for what we are actually good for and get your money's worth from us.
Thank you very much.
Thank you very much.
Over 17 minutes. That was a great.
Oh, I'm sorry.
No, that's fine. Completely fine. We had 5 minutes of questions and answers anyway. There aren't any questions on the chat. So if anyone has any questions, please feel free to leave it on the chat.
Can I come in, Osama, while you're thinking about that?
Of course.
Yeah. So, Stephanie, my question is twofold. First of all, in your practice, does every patient seeking bariatric surgery have to see a psychologist preoperatively
Yes.
or not? And then, well, thank you. And out of, let's say, 100 patients you see, how many would you say are unsuitable for bariatric surgery? Or would you advise, I mean, forever or for some time period? And how many would you let progress to surgery without any problems?
So I think Dr. Goodpaster's talk is going to cover this in much better, more, and I'm sure better detail. But I have almost never said this patient should not have surgery. There are patients for whom I say, in order to mitigate some of the psychosocial risks, I would like to see these things happen before surgery. But I can almost think of no times when I've ever said this patient should not have surgery. Because again, I'm not a gatekeeper. And I know Dr. Goodpaster is going to talk about this. I don't want to step on her headline, but this is a necessary medical treatment. So I'm not going to get in the way of it. My job is to make it go better, not to screen people out and see who shouldn't do it. Everyone, it's the best treatment we have. So ideally, everybody should do it, but we need to make sure they're going to do well and not have these major risks.
I'm going to just press on that issue just a little bit more, because it's important for our patients who are on the call today, as well as many of the colleagues. So you see everybody and you rarely turn people down. So just to understand the resources you have, how many operations would your service do in a year, and how many psychologists do you have to provide that service?
You know, I should know how many we do a year, and I don't. And obviously our numbers are skewed by COVID right now. We have 4 surgeons, and we have 2 full-time psychologists and 2 part-time psychologists and a very, very part-time intern. But so sometimes if there's sort of a little work to do, we will do the work with the patient beforehand. Sometimes we're saying that the patient really needs to be in the care of a therapist or counselor, just to make sure that there's somebody who's monitoring them and working with them more closely before and after surgery. And other times it's other things.
Before Osama interrupts me, I'll just press on. So let's say, we don't know the total number of surgeries, but we know that there are 2 psychologists and 2 assistant psychologists in your service. So 4 of you, how many new patients would you see in a year, roughly? I'm trying to understand how many psychologists we need in our services.
Several hundred.
Several hundred.
But we also do non-surgical weight loss, so that some of those are going to be for patients who are not seeking surgery, or who have already had surgery in the past, and we're helping them.
I mean, I would love to hear this from Vanessa, because I'm openly discussing for many colleagues who speak to me and who have spoken to me over the decades on this issue, I think almost, and patients. So many services have 1 or 2 psychologists, and they do 100 or 200 operations or patients. That's not the sort of volume that you wouldn't be able to provide the treatment that you're providing for, or am I jumping to conclusions here?
Sorry, is that question to me?
Yeah, Vanessa, please. So I'm just saying, most teams have 1 or 2 psychologists, and they do between 100, 200 cases on the NHS, So we should be able to support patients through rather than turning them down.
Yeah, I know, I absolutely agree. I think there's variability depending on services. I'm no longer in the NHS, but the experience in the NHS is that often the posts are, I think, as Steph said, some is weight management and some is surgery assessment. Services are commissioned differently. So some services are commissioned for the psychologist just to do the assessment or just to do the post-op. So I think there's lots of variability there that makes it difficult to be able to say these are the numbers that we should be seeing. But I absolutely agree. I think, that the sense of the assessment process and the work with a psychologist about optimizing outcome, and the position I take on that is it's not necessarily a no, never, but it's a not yet. So it might be that there's some support that the person requires to help with surgery. The access to that help within the NHS, that's variable. And so I think that has an impact on timing.
Fantastic. So we'll discuss more in the discussion later. Hand over to you, Osama. Thank you.
Just joined. We've got 2 more great talks, and then we can have question and answer session after that. Next is Casey Goodpaster on which patients should not be offered bariatric surgery on mental health grounds. Casey is a clinical health psychologist special in bariatrics and weight management. She graduated from the Counseling Psychology doctoral program at Purdue University, achieved a pre-doctoral internship in adult health psychology and neuropsychology at St. Vincent Indianapolis Hospital, and is a postdoctoral and had a postdoctoral fellowship at the Cleveland Clinic Bariatric and Metabolic Institute. Casey has extensive clinical experience in the Portland and the Cleveland Clinic, as well as clinical work, conducted research, supervised psychology graduate students and postdoctoral fellows, and contributes to the whole program development. Her clinical interest includes health psychology, psychological assessment, pre-surgical evaluation, bariatrics, and body positivity in the context of weight management. So Casey, over to you.
Thank you so much. Thank you so much for having me. And I wanted to applaud Dr. Sog. That was an amazing talk. It really helped to sell our profession, I think. And I'm looking forward to more questions and answers about some of those topics that were brought up afterwards. So she obviously provided a really compelling argument, of which I totally agree, that psychologists are not gatekeepers for surgery. Our goal is to help get patients to surgery, help optimize their outcomes, support them in adjusting to post-op lifestyle changes. But I will warn you that my portion of the presentation will sound a little more gatekeeperish, because I'm going to be talking about the absolute contraindications. And as a side note, this is the piece of the job that I dislike the most. I really, really love more of the supportive aspects of what we do, but there are some situations in which the risks of surgery really do outweigh the benefits at that time. And so I'll keep throughout this talk referring back to the scale, the balance between the medical and psychological risks of surgery and the medical and psychological risks of continued severe obesity. So you might be wondering what I'll be basing my recommendations upon. And that is, what guidance do psychologists have in determining contraindications? And it turns out there is more gray area here than there's black and white. The 2019 update to the ACE-TOS ASMBS clinical practice guidelines indicate that patients should undergo a formal psychosocial evaluation, particularly those with suspected psychiatric illness or substance abuse. The guidelines, however, did not specifically state what those psychological contraindications are. And the same was true of the 2013 update to these guidelines. So let's step back in time and see what guidance we've previously received about contraindications and what has in turn shaped our practice. We did have some more concrete guidance from previous iterations of the ACE-TOS ASMBS clinical practice guidelines. In fact, 3 of the 4 exclusion criteria listed were related to these psychosocial risk factors. The contraindications were listed as current drug or alcohol abuse, uncontrolled severe mental illness, and lack of comprehension of risks, benefits, expected outcomes, alternatives, and lifestyle changes required with bariatric surgery. So this is a good starting point. Of course, it still raises a lot of questions. And over time, the guidance that we've received from professional societies, though, has become a bit more vague. So when there's not much guidance from professional societies, we also look at what is considered best practice among bariatric experts. And listed here are the top 10 most commonly cited contraindications in a survey of present practices among 81 bariatric programs. And I use air quotes with present because this study is now outdated. It was from 2005, but it is the most recent survey that we have. And still, many of these criteria are commonly used today, and they have shaped which patients have been offered bariatric surgery, and thus those who have been included in research studies. So ultimately, the candidacy for surgery is decided at the program level. And here I'm going to show you what our contraindications are at the Cleveland Clinic. And it's to answer a question that was brought up earlier, what percentage of patients are not offered surgery? I would say less than 5%. And even among those 5%, they will eventually become candidates, but we require that they have a period of stability or a period of being free from substances, which I'll get into a bit later. And again, different bariatric programs might use similar types of criteria, but they might have a different length of time that they would require somebody to be stable or free from substances. At the clinic, that's generally over the past 1 or 2 years that we would like to see them free for these concerns that are listed here. So I'll next spend a bit of time talking about why we consider those factors to be contraindications and some major areas of concern that shape our recommendations. And just to set the stage for what I'll discuss, it's important to know that there is a higher base rate of psychopathology in bariatric patients versus the general population. 25 to 30% of bariatric candidates report current depression at the time of the evaluation. 50% report lifetime prevalence of mood or anxiety disorders. And there's also a very high rate of psychotropic medication use. So close to half of patients report current use of these medications for their mental health, and 73% report lifetime use. And why is that important? Well, the pharmacodynamics of surgery are not well understood, but research does suggest decreased serum levels after gastric bypass compared to pre-surgical levels of these antidepressants listed here. And dose adjustments are common. Oftentimes there's a need for an increase in medications in post-bariatric patients. And close monitoring about the need for adjustments is really vital to prevent exacerbation of psychiatric symptoms after surgery in our population, which, as I shared, is already psychiatrically vulnerable. So next we'll talk about suicide. This is the most severe psychiatric complication and the first on the list of the contraindications that I showed you before. So risk factors for suicide generally include psychopathology, including depression, anxiety, personality disorders, and eating disorders, all of which are higher in bariatric samples. Substance abuse, which is another risk factor for bariatric surgery that I'll discuss later. Chronic medical illness. In fact, risk of suicidal behavior among those with chronic medical illness is between 2 and 11% times greater than in healthy adults. And obesity itself is a risk factor for suicide. But the very biggest predictor for future suicide death is past suicide attempts, and bariatric patients have a 73 times greater prevalence of past attempts compared to the general population. So all of that should tell you that our patients are at high risk of suicide. Indeed, a recent meta-analysis showed that there was a higher rate of suicide among bariatric patients compared both to the general population and compared to age and BMI matched controls, about a 2-fold increased risk of suicide compared to the general population. And that might even be an underestimate, as the study only included confirmed suicides. So there's also a higher rate of accidents and substance-related deaths, which could really be masked suicides. So of note, about 30% of suicides occur within the first 2 years after surgery. So going back to that scale that I showed you earlier, kind of balancing out the risks versus the benefits, the risk of suicide after bariatric surgery will outweigh the benefit among patients who have recent suicide attempts, particularly if there have been repeated suicide attempts. Next on the list of contraindications, we'll discuss related concerns related to poorly controlled severe mental illness. Research about severe mental illness such as schizophrenia and bipolar disorder is lacking because I think, as Dr. Sog alluded to, these patients typically are not offered surgery and they're not then included in our research studies. So the information we have to go on is really limited. But the main concerns we have here include problems with reality testing and impulse control, both of which could put patients at risk. There was one.
5 minutes left.
Oh, thank you. There was one small uncontrolled study of patients with bipolar disorder and schizophrenia. And though weight loss after surgery was no worse than expected, again, that's not the only outcome that we should consider. Psychiatric deterioration occurred for all 10 patients for which the data was available within a 4-year post-op timeframe, although most data was from 2 years post-op. And within that period of time, 100% had an increase in psychiatric symptoms such as paranoia, hallucinations, or self-harm. 90% had changes made to their psychiatric medications, and 20% required inpatient psychiatric hospitalization. So these psychiatric risks for patients with ongoing severe symptoms such as psychosis and mania thus outweigh the benefit of surgery. So we'll talk about substance abuse next, starting with a little bit of context about our population. So although current substance abuse and dependence is lower than that of the general population, lifetime history is more than double. And it's important to note that surgery will not cure an alcohol use disorder. 62% who had an alcohol use disorder at the pre-op assessment continued to have an alcohol use disorder within the first 2 years post-op. And current drug or alcohol abuse is widely considered to be a contraindication due to concerns including perioperative health and safety risks, and secondarily could potentially affect weight loss outcomes and overall adherence. And many patients develop problems even if they didn't have problems at the time of surgery. And one major reason is that bariatric patients have increased sensitivity and reduced tolerance following surgery due to changes in their anatomy. One drink will affect them as if they had 3 to 3.5 drinks, but the symptoms of intoxication are different. So a whopping 1 in 5 patients develops an alcohol use disorder within the first 5 years post-gastric bypass. That risk just seems to increase with time post-surgery. And this graph also illustrates that illicit drug use increases over time as well. So what do we do about this? At the Cleveland Clinic, we require a period of abstinence from illegal substances, which we require documentation with a series of negative toxicology screens. Alcohol is more difficult to assess, but we do require documentation that they completed substance abuse treatment successfully. And we also rely on informed consents and behavioral contracts, and have patients who are at risk of relapsing attend a 90-minute psychoeducational group that's designed to educate them about the risks of substances after surgery and help to engage in relapse prevention planning. Okay, so a little bit about eating disorders next. Many patients seeking bariatric surgery meet criteria for an eating disorder, the vast majority being binge eating disorder. Graze eating and night eating are also quite common. And research is mixed about the impact of these eating disorders on post-op outcomes, but it does tell us that pre-op disordered eating predicts post-op disordered eating, which in turn is associated with less weight loss. Binge eating, graze eating, and night eating syndrome are not often considered to be absolute contraindications for surgery, but eating disorders such as atypical anorexia and bulimia would pose very high risks, including risks of nutritional deficiencies, dehydration, ulcers, and electrolyte imbalances. All right, and lastly, we'll briefly discuss cognitive impairment. So there are many considerations for patients with cognitive impairment. Research does suggest that the metabolic benefits of bariatric surgery can in turn improve cognition for some patients, but patients with very low intellectual ability, IQ of less than 50, or suspected memory impairment should be referred for neuropsychological testing, which is a more thorough battery, in addition to imaging in some cases, to help determine the etiology of the cognitive problem. Patients with progressive brain disease, such as Alzheimer's, are typically not considered to be candidates. As the illness worsens, they will have greater difficulty adhering without intensive assistance in activities in daily living. And in advanced stages of the disease, there can be difficulty with swallowing and other medical issues that would be very difficult to manage in the context of the bariatric lifestyle recommendations. But for non-progressive forms of cognitive impairment, for example, due to stroke, baseline low intellectual ability, neuropsychological testing can also assist just in ensuring patients can provide consent for the procedure, they can recall and adhere to the lifestyle recommendations, And also that testing can inform the team of how patients learn best. And support is crucial for everybody, social support, but particularly for those with cognitive impairment. So it should be a requirement that support persons are involved in the process, if that's the case. And at the clinic, we also rely on bioethicists. They can be involved in assisting the team in weighing the risks and benefits of surgery and other ethical considerations. And that really goes for many of the concerns that we have discussed so far. So I know my presentation was it probably seemed a little bit more black and white, but really the truth is there's far more gray when it comes to determining a person's readiness for surgery. And again, most patients are deemed candidates, but for a very small percentage, the risks outweigh the potential benefits at that time. With intervention, which I don't have the time to discuss today, we do know that most patients who are not currently candidates can become candidates. And in some, it might be the right surgery, it just might not be the right time. Thank you.
Thank you very much. That was very interesting. I was hoping to ask, I think you mentioned in your slide about drug and alcohol substance abuse. You mentioned that they have to be abstinent for a period of time. How long was that period? Sorry, I might have missed it.
No, I chose to not include the timelines on the slide because I know it differs from program to program. In our program, we usually say 1 year of abstinence from illicit substances. With marijuana, there may be some differences because it's the legality of it in the US is different from state to state and stuff. But we would look at if a person was addicted to a substance such as marijuana before determining the timeline that they needed to be free from the substance.
Sure. And what proportion would you say, Casey, that would decline surgery because of abuse and then can be reconsidered again and go ahead with surgery?
That would fall within like generally that 5% range, which would also include the other contraindications. So I don't know, I can't say for sure what percentage of among that 5% might be due to substance use, but I'll also say that we in our program do some screening before the patients get to the psychologist. Before they enter into the program, they complete a questionnaire about medical and psychological issues. And so if there was an indication on that questionnaire that they were currently abusing an illicit substance, then they would not have entered into the program in the first place. So I suppose I don't know what percentage would have just not entered into the program for that reason.
Okay, great. There's a couple of questions from the chat, if you don't mind, Casey.
Sure.
Would you consider tobacco smoking to be an illicit substance from
So no, that would not fall within what I was sharing in terms of the substances, but we do require as well that patients do quit smoking. And our protocol currently is that for the sleeve, they need to be quit for at least 1 month and submit a negative nicotine screen, or for the gastric bypass, they need to be quit for a total of 6 months and have multiple nicotine screens over that period of time. But I wouldn't call it an absolute contraindication. It is part of the role, though, of the bariatric psychologist in assisting patients and quitting smoking and referring them for smoking cessation resources.
Great. One last quick question. Would you treat illicit substance, i.e. recreational use, differently to abuse and addiction?
When it comes to marijuana, yes, but when we have even just recreational use of another illicit substance, cocaine or heroin or something like that, then no, we do take a really firm stance about that they need to be completely free from all substances for that period of time. And again, that's going to differ from program to program.
Great. Thank you very much, Casey. I really appreciate that.
I just have a quick question to ask, if I may, yeah?
Of course.
Yeah. So, Casey, you said that the bed is not an absolute contraindication, binge eating disorder. And you didn't mention about trauma, but previous trauma didn't come as a contraindication either. So anecdotally, I'm aware of lots of patients being turned down from surgery because they either have bed or have had previous trauma. What's your view on that? Is it right, or they can be made suitable, and what would you recommend, and how long does that typically take?
I would not agree with that, ruling somebody out for having experienced trauma, because rates of trauma they're extremely high in our population. And obviously that's not a patient's fault if they have experienced trauma. That being said, if they have current post-traumatic stress disorder symptoms that are, impairing, then I would recommend that they seek treatment for that, because the post-traumatic stress symptoms can worsen post-surgery. And I guess more anecdotally, if a person has had sexual abuse history, then the weight loss can trigger feelings of vulnerability and that way, and being seen in a smaller body. So it's important to get support, but I would say both with that and then the binge eating disorder, those fall more within the gray area. It's not so black and white. We would really try to tailor our recommendations for what kind of treatment that patient would need to minimize the risks.
Thank you.
Thank you.
Again, we better move on. Last but not least, the UK-based Vanessa Snowden-Carr on the adjustment after bariatric surgery and the impact on mental health and well-being. I know a few of the attendees have mentioned post-operative assessments, so it's best coming from Dr. Snowden-Carr. She's registered with the Healthcare Professional Council, is an associate fellow and chartered clinical psychologist at the British Psychological Society, and a member of BOMS, of course. Completed her clinical psychology doctorate at Cardiff University, and she's been involved in a range of national policy developments to highlight patients' psychological needs within bariatric surgery and obesity surgery, working with the Royal College of Surgeons and representing the British Psychological Society on the National Institute of Clinical Excellence, NICE, Clinical Commission Group for Bariatric Surgery. Dr. Snowden-Carr also provides training and workshops both nationally and internationally on the subject of obesity, weight stigma, and bariatric surgery. Vanessa, over to you.
Thank you. And thank you very much for inviting me to be part of this panel today. Great speakers that we've had so far. The purpose of this part of this last presentation is to think about the experiences for people after surgery. So we can think about it in terms of mental health, but more broadly in terms of well-being as well. So it won't be what we need to be assessing, but it will be more about what are the tasks, what are the adjustment tasks, and how that is impacted upon by well-being. So let's start with, there we go. Let's start with this, this slide from the paper in 2016. And what this did is it looked at weight trajectory over time, and it highlighted the rapid weight loss phase, but labeled it as the honeymoon phase. So this is the sort of the good bit after surgery when weight loss is occurring. And it's for gastric bypass particularly, but the same is true for sleeve. It's not until post 15 months that we start to look at the difference in terms of weight trajectories. The idea that somewhere after 15 months is where the work begins is that actually I would disagree with that. I think the work begins much earlier on. And what I want to do in this conversation is to highlight some of the tasks of adjustment after surgery. But let's think about it in terms of literature. So we know that bariatric surgery has an incredible impact on physical quality of life, physical health benefits. But actually the impact on mental health remains unclear within the literature. The quality of life isn't necessarily associated with significant mental health gain after surgery compared to a non-surgical intervention. And in terms of longer term impact, there are no consistent findings with regards to mental health. We know that as complexity increases with regards to mental health, weight impact post-operatively occurs. But the relationship between what's happening pre-operatively with regards to depression, for example, and weight regain is less clear. So in terms of what the speakers have said previously, the difficulty around having predictive factors makes it hard to be able to say, these are the people and these are the experiences they're going to have after surgery. So what I wanted to do, rather than talking about mental health and talking about the diagnostic labels, is to think about the spectrum of mental health. It's a huge umbrella, a bit like obesity. And what we see is there are very many different presentations within that, different experiences within that. And this continuum highlights some of the experiences that people have at different points in this continuum. So looking at this, what we'll be able to see straight off is that there are a few of these areas that are absolutely impacted upon by virtue of having surgery. But when we're talking about whether somebody's struggling after surgery, we need to know to what extent, to what degree. So how does mental health impact on life after surgery? Well, all of these areas have been found repeatedly within the literature to be linked to difficulties with mental health. And if we think about the tasks of adjusting after surgery, all of these can have a role. So for example, if I'm struggling, if my mood is low after surgery and I'm withdrawn as a result of that depression, then I'm going to find it difficult to engage with my support services. And we know that there's an impact between regular follow-up and outcome. So we would want to encourage people to attend outcome. We know that if I'm anxious and I'm developing anxious cognitions, then I'm going to struggle perhaps to adjust to coping afterwards, and I'm going to doubt myself. So all of these different elements will have greater or lesser degree impact post-operatively. So I want to talk about this journey with surgery. And it starts way back, probably before we even see patients in our services, that decision to have surgery, to seek support. But for this conversation, I want to start with the pre-op side of things, the pre-op preparation. So the point at which someone has come into the service and they've been approved for surgery and they're waiting for their surgery. This pre-op stage is practical. It's where our behavioural experiments are recommended. So testing out some of the things that people are going to experience after surgery, taking an element of it at a time. So for example, experimenting with 30 minutes either side of eating from fluid, experimenting with slowing the pace of eating. But it's also a time of emotional preparation. So we see it in diets regularly where people will stock up, for example, in advance of starting a diet, but we see it preoperatively where people are anticipating not being able to eat in the same way, or at least for a while. Sometimes people will have periods of time where they'll go out and socialize or might have a drinking binge in anticipation of having to stop after surgery. The next stage is the liver reduction diet, and this again is very practical and very focused. It's where people are, whilst the diet is difficult, people are able to manage it because it's a means to an end and it's short-lived. It's a time of excitement, but it's also a time of anxiety, anticipating the surgery. Then the surgery itself, and we're assuming that it all goes well without any complications. So the next stage is in the immediate recovery stage, the post-operatively, which is very physical. The experience of pain in the left shoulder, the experience of worry about damaging yourself in your stomach. It can be a time of relief in that it's finally done. But it can also be a time where people are questioning, what have I done? Was it the right thing to do? There's a balance between having an intensity of overwhelming emotion that people can experience with sometimes an absence of emotion.
5 minutes, Vanessa.
Sorry?
5 minutes left.
Thank you. Okay, so we're in a text to progression diet again, which is very physical, very focused. People have something to follow in terms of a plan, but there can be an anxiety about pushing themselves. So sometimes people stay longer in this stage than they might otherwise do, than other people do. Sometimes there's a hurry to return to regular food or to textured food. And so people are moving that on quicker. Sometimes that's influenced by the perception of other people, whether people have told others about their surgery, whether they're returning to work and they need to get on with day-to-day activities. In the first 3 months, the tasks are around learning how to adapt to new body signals. There's excitement with weight loss, frequently weighing, sometimes multiple times a day. There's an energy that comes with that weight loss, but it's not as prescriptive as previous stages. So people are trying to find their way a little bit more, questioning, am I doing it right? So anxiety can occur there. In the 3 to 6 month stage, again, there's an energy of change. The pace of weight change is continuing. People are noticing health benefits in this stage. So maybe less shortness of breath, maybe a change in blood pressure. Other people are noticing perhaps weight now, and that can be both positive and negative, depending on how, whether people have told others about their surgery. Going out and socializing, reintroducing that can be a time of anxiety for people, and difficulty around managing hair loss, brittle nails, temperature regulation. But it's also a time where people begin to notice what they haven't been able to do because of their weight, and beginning to face these new things. In the 12-month stage, we're beginning to see a slowing of weight loss. People are able to eat a little more, increasing in appetite, and it's a time where weight can start to fluctuate a little, and that can be hugely anxiety provoking for people. It can also be a time that is relaxing. People have got a sense of, right, okay, I know how to do this now, and feeling like they're getting their groove with it. But anxiety about maintenance. So thinking about, has anybody, have people maintained weight preoperatively before? They can be very good at losing weight and regaining weight, but actually maintenance might be an entirely new task for people. We get at this point the split between physical recovery and psychological recovery, and often they don't sit, they're not parallel. Our physical recovery can be significantly quicker than the psychological adjustment and recovery. We can think about where old habits start to creep in, and what strategies we've been able to learn earlier on in the surgery before this point. Excess skin becomes a focus here as well. And the majority of people, when asked preoperatively about excess skin, will say, actually, I understand it, but I would prefer it to how I am now. But that isn't necessarily the case after surgery. There's also less validation. So people are not commenting perhaps as much about weight change. And for some people that might be a relief. And for other people, it might impact on motivation or maintaining. And then when we get to 18 months post, we're in a maintenance phase. So this is another part of where the work is. How are people able to keep their focus when it's not new anymore? The novelty's worn off. What happens when weight regain occurs? The sort of the natural normal weight regain that happens to some degree. What does it trigger in terms of sliding thoughts? It's like, I've blown it, it's not worked for me, I can't do it. A time of self-reflection, of being able to think about how things were and how things are now and what's ahead for people. But also that the navigating what is the fantasy and the reality. So what did I imagine it was going to be like at this point? And then how is it? What am I able to do? What am I not doing? What's happening in terms of emotional coping and life stresses? Now, life stresses obviously will go all the way through the journey and can have a significant impact. So a person can be managing incredibly well, and then life throws a curveball at them and it knocks everything off course. But it can work the other way as well, where there's some really positive things that can occur in life that can help adjustment and coping afterwards. And this is a really important one, because an experience we had within our service a number of years ago was of a patient who had a very significant trauma a week before their surgery, and they were very worried about telling anyone because they thought that their surgery would be postponed or cancelled, and so they didn't disclose it. And we did, as a team, we didn't know this had occurred, and all was well, and they managed very, very well when they were in the very focused stage, when they had a plan to follow. But when they got to about 12 months, the trauma overwhelmed them, and they significantly struggled, and in fact they ended up taking an overdose and dying. So life stresses are hugely important, and as we talked about before, we can't predict these things that are occurring in life. And as psychologists, we can talk about how somebody might have coped in the past, but we're not able to say with any certainty how they're going to be able to cope with these unknown things ahead in life. So we can't risk assess everything. So thinking about some of the experiences from a patient's perspective. So this is from a book, although it's an older book now, it's a really beautiful qualitative research and captures patient experience really well. So some of the experiences, this talks of relationship change and how perception of someone who was close to this individual thought that she'd taken the easy way out, and it had an impact on her and her relationship. This speaks of the anticipation of change with weight loss and the focus on if you lost a bit of weight then, and then when actually that doesn't happen after surgery, and how significant that is. People can be prepared for all sorts of things in advance of surgery and do a lot of research and a lot of work in advance, but then some things will blindside them. And then this speaks to that idea of split between physical recovery and psychological recovery, and how that takes time to catch up. That identity and body image takes time to catch up. So we can think about mental health and its pre-operatively and the experience that has on bariatric surgery, as we've talked about, that's less certain. We can think about how the experience of bariatric surgery impacts on our mental health and well-being. But we also have to recognise that this relationship with our mental health might be independent of bariatric surgery. And this happens just to be another thing that's happening, that is occurring along the way. It's why we wanted to put together some guidelines for recommending psychological provision, both pre and post-operatively. Partly in the UK, we have the NHS and private practice. Most NHS services will include some degree of psychological provision. At the time of writing it, very few private practices did. So we wanted to pull this together and recommend that all services have access to psychology, but post-operatively as well, and post-operatively routinely, ideally around 6 to 9 months, to be able to catch some of the changes that can occur earlier. So adjusting to bariatric surgery will absolutely be tough at times, and a change in mental health presentation and well-being makes it tougher. So back to the question about what we assess and how we think about patients in advance of surgery, is our focus is on stability. Is how stable is somebody going into surgery? Because we've talked about the huge task that there is in adjusting to life after surgery. And if a person's going into it and not feeling very stable with their eating habits, with their mental health, then actually it's going to make recovering after surgery significantly difficult. So that's our focus. Is a person in a place where they feel stable and well enough to be able to thrive after surgery? Thank you.
Thank you very much, Vanessa. That was amazing. That was great. Yeah, I think overall, this is exactly what we've been looking for at TUGS. It's a great discussion, 3 great presentations, perfect timing, and excellent slides, and overall covered most things that everyone would like to know in terms of a multidisciplinary approach. There's a couple of questions that we can address from the chat.
While you're looking at them, Osama, may I ask the first one? So, Vanessa, thank you very much. And as Osama said, I agree entirely. It's a great talk, and I personally learned myself so much. So my question to you is, does every patient need post-op support? If yes, that's the obvious answer. And if no, then what percentage and how do we identify them?
So I think in terms of percent, so not necessarily every patient would need post-op support, I think is the first thing. I think one of the things that we tried to do in the paper that I made reference to is highlight a stepped care or a stepped model care. And so highlighting, we can support our team members to be able to identify earlier problems. And obviously the dietitians are going to be in regular contact with patients, as may the nurses as well. So being able to pick up some of the early warning signs that somebody is struggling, and then to be able to triage them is this online resources, is this self-help, is this a group type of intervention, is this a one-to-one with a clinical psychologist? So you have those levels of care.
Typically, what percentage of patients will ultimately end up seeing you in your experience?
So in the I think probably about a quarter of the patients in the service that I would work in would end up having some degree of contact. And that might be a one-off. It might be a one-off conversation that is about signposting or exploring what's happening. It might be about tapping back into, and this is why the pre-op assessment can be so helpful, because we can go back to some of the strategies, some of the issues that were highlighted at that pre-assessment point. And also for people, they're not seeing a psychologist for a first time, which can be anxiety provoking. So the psychologist is familiar.
Yeah, no, I mean, look, I'm just trying to understand, what sort of service provisions teams and services would need in terms of the psychologists to be able to deliver what we are asking them on this call, really, and to me, it seems like a service that is doing a few hundred procedures every year would really need at least a couple of psychologists and some assistants and 2 assistant psychologists as well, and to do everything that we really should be providing patients.
I think it's a really, really important question. And it's one that we don't have a good answer for in the UK, at least. There's scoping work that's being done, mapping work that's being done to be able to try and help services identify actually how many psychologists do we need in a service, and what kind of psychologists do we need, what level of expertise do we need. And we don't have consensus information on that at the moment. And I don't know whether you do in the States.
Yeah, I mean, in terms of service configuration, it would be nice to hear, Osama, are we now moving to the panel discussion part?
Yes.
So, I mean, in terms of, just broad experience and maybe, we'll start off with Stephanie now and go on to Casey and then Vanessa. In terms of service provision, I don't know which denominator to give you, but let's say a service gets 500 referrals for bariatric surgery every year. So what would be your sort of psychology, mental health game plan for that service?
I mean, I think the bottom line here is a question of resources. And I think that we often base our clinical protocols on what's possible with our current staffing levels. And I would encourage people to start from what do we think is needed and how big a gap is there between what we need and what we have the resources for, and do we need to change our resource allotment?
So thank you, Stephanie. Casey, do you have any thoughts on that at all?
I agree with Stephanie. Currently at the Cleveland Clinic, we are lucky enough to have 6 psychologists devoted only to bariatrics. And we did, I think, 600 surgeries last year. But being that we have such a large presence, we're able to offer more services than other programs might provide. So we have several different types of group programs, both before and after surgery, to help our patients with these pre and post-op issues, for example. But again, most centers do not have that type of staffing level. So I agreed with what Stephanie was saying of just starting with what do you most need, and then you can build from there. And I think when you have that psychology presence on your team, I mean, we do a good job of then selling ourselves, and your team will see the value of having psychology, and that's how it begins to grow and the services expand.
No, thank you, Casey. I get what Stephanie was saying, in terms of stretch yourself as much as you can and not where you want. I get that, but I'll come to that point in a little bit as well, as to what are the priority areas. But just for the discussion, see, you seem to suggest that one psychologist per 100 patient would be a good number to aim for, sort of idealistic aspiration, if I may. Would that be a reasonable summary of what you said or not?
Probably.
Okay. Well,
it's very hard to quantify, I guess,
it's
since
informal.
programs are so
Now,
different.
coming to Vanessa. Vanessa, numbers in your head, what would be the sort of configuration numbers? And the second one from UK perspective, obviously, because you and I live here and work here, do we have that resource in this country or not? And if not, then where can we cut?
So in terms of the number, again, I think that that has to be properly mapped. And I think that for Stephanie's point about needing to think about what we provide, I think one of the things that we do in the UK is that because we have a very limited resource of psychology in reality, very, very few services have more than one psychologist. If you have a whole-time psychologist, then we're really lucky. But so what we do instead is we support our dietetic and nursing colleagues who have incredible psychosocial skills. And actually, so it's being able to think about the psychological work by the clinical psychologist, but the psychological work, the psychosocial work by the rest of the team. So it's not just the psychologist that has the psychosocial conversations, it's the broader team. So I think I'm aware I'm kind of avoiding your answer or your question about the kind of trying to pin me down on a number. And it is a chicken and egg, is that, do we start with where we are and think about how we map it? Do we think about sort of magic wand and say what we ideally would look like or should look like? And I think that's difficult, but I think that the scoping exercise to be able to say what's a basic minimum of psychology provision in a service per number of patients, I think that will be really important work to do, because that at the very least will help us with sort of safe practice.
Look, I think Vanessa, well done for answering that. But I think you've answered most of my questions, and sometimes the answer to a question may be that it's not possible to answer that, and I think we all get that. Now, in a service, and let's hypothetically say that a service is so resource constrained that they have to discharge or turn patients down, let's say 30, 40, 50% of their patients down, and not let them progress to surgery on mental health ground because they haven't got psychologists. As a psychologist and as a leading psychologist in the UK, and may I say globally, because you're leading figures in the world of psychology in the world, do you think it's a good situation? Do you think it's an ethical situation?
Well, let's take out the psychologist word and talk about an anaesthetist, or talk about a surgeon, or talk about any other member of the mental health of the surgical team. If we didn't have enough of those people and we couldn't therefore provide a service, where does that leave us? I think we always kind of come back to how the lack of psychology resource is hampering the throughput of services. But actually we have to think about it as a whole team responsibility.
That's very well pointed. Great point, well made, Lisa. Thank you very much for that. Osama, I'll let you lead the next round, and if there's time left, I may do another round of questioning after that and discussions.
I think I was interested in asking, especially between the UK and the US. I mean, having worked in different centers, are there different criteria that you would rule out patients for? And is there any way of kind of standardizing this nationally or maybe internationally for mental health, for bariatric surgery, I mean? Casey?
Yeah, do you want to start in from the US perspective?
Sure. I can say that having worked in different bariatric settings, that the general contraindications have been the same, but maybe the length of time has been different of stability needed or being free from substances. And the trouble with trying to standardize it is that we do not have the research to support any specific amount of time, since there's so little research about patients with these concerns getting to surgery. we aren't able to really draw upon anything really firm in making those standardizations.
Thank you.
And I would agree. I would agree. You know, we're not able to do a tick list assessment, and so it makes standardized. So we have a shared agreement about the risk factors from the research as far as we can extrapolate those to impact after surgery, but we don't have a clear, these are the boxes we need to tick in order for this person to proceed. It is based on individual experience and capacity and context and all of the other things that are formulated within an assessment.
Thank you very much. There's a couple of questions on the chat. I think this is to Casey. There's a question about a patient being on the autistic spectrum and very dependent on his parents for socioeconomic support. What sort of milestones would you want for him to hit before surgery, or would he not be a candidate at all?
We do not consider autism to be a contraindication in our program, but it would be something to where this individual would need a lot more assessment and support. It would be important to evaluate if this person has the capacity to consent to the procedure. How severe is the autism? If the parents are the medical decision makers, it's helpful to at least get the patient's assent that they can understand what's going to happen to them and they can verbalize the lifestyle changes needed. We would involve the parents in the process. We would want them to attend some appointments as well and be demonstrating that change can be made for this person. So oftentimes patients with cognitive impairment, they do get to surgery, but it takes a lot more appointments to help them understand it. They might have different methods of learning or methods of instruction that we need to provide to them so that they can learn best. And I think one other thing is when you have somebody who's relying a lot on a parent who has cognitive impairment, that you also have a discussion when the parents pass away, who's then going to be the support person, and make sure that's identified in advance as well.
Thank you. There was another question about any centers that exclude people with personality disorders from bariatric surgery, Casey.
I have this sense some places do. I think it depends on the resources that are able to be devoted. We at the Cleveland Clinic don't. It sounded like that our center has a similar kind of approach as what Stephanie was saying, that we feel comfortable operating on patients with a lot more complexity across the board because we feel confident that we can support them and we can educate them about the risks and get them resources and things like that. But I do believe other bariatric practices might not feel comfortable working with such patients.
Thank you. I think there was another question for Stephanie, perhaps. Can you identify good self-directed resources for patients? For example, building confidence, dealing with anxiety, etc.
So I did put in the chat, I'm going to put in a plug, and I refer at least 4 or 5 patients per week to this book. Denise Ratcliffe, who is a psychologist in the UK, has written a fantastic book called Living with Bariatric Surgery. And I have just been blown away by how comprehensive it is. She sort of has touches on every possible kind of psychosocial issue or experience that I have run across in my 18 years of working with patients who are going through bariatric surgery, and has a lot of, and she wrote it, she actually collaborated with patients to write it. So I recommend that to most of my patients. And I also recommend that other providers read it so that you're getting a good sense of what some of the psychosocial issues or experiences may be. I mean, there's lots of different resources in general for, you know, I think one of the questions was anxiety or what have you. That would, I mean, it would be sort of a whole
day-long seminar to talk about which of those resources are helpful. But specifically regarding bariatric surgery, Denise Ratcliffe's book is fantastic, and I recommend it to pretty much everybody.
Yeah, I second that as well. I used to work with Denise in Chelsea and Westminster Hospital in London, and she's a great psychologist, and her book is truly amazing. Thanks for that, Stephanie. I can't seem to identify any more questions.
Sama, I'll come in that case, and I will third that comment. You know, many colleagues and patients have told me that that book is outstanding and excellent. I haven't read it myself, but I think from what I've heard today, I should probably as well. So this is going to be my maybe New Year's reading list thing. I will add on to it.
It's an easy read. It's a pretty quick read. Highly recommended. No,
it's definitely, you've convinced me. And if if you speak to Denise, just tell her that we all highly appreciative of her efforts in the field, and we're grateful. I'm going to ask you all one more difficult and slightly thorny question. You might be expecting it anyway. You might have been. So you see, the issue of trust and confidence lies at the root of medical practice. Whatever my patients tell me, I trust them to tell me the truth, and that's how I can look after them. I don't go second guessing what they tell me. That's the norm in the physical health world where I work in. I don't cross-check a patient's information with their family or anybody else. What they tell me is the truth. I rely on that, and I make judgment on that basis. In the mental health world, I think it is somewhat different, and it may even be difficult. So enlighten me. When you do toxicology screens and when you do cross-checks because many patients do perceive mental health as a barrier to their surgery. And I understand that some may be less forthcoming with all the details than others. But where does the responsibility lie? Because if a patient does not tell me the full story, I don't come to any harm if I do the surgery. They do, isn't it? Because at the end of the day, it is their life. And how much of control of their life do they have, and how much of the responsibility we as healthcare professionals do? It's a very difficult, ethical, difficult question. I'll start off with this time, maybe Vanessa, you, and then we'll go in the reverse order. Thank you.
I think I would take the same approach as you in being able to think about the person's responsibility in the information that they share. I think part of our conversation with people in advance of surgery and during the process of after surgery is about being able to explore where they're feeling stuck. And very often people will say, I'm saying this, but I don't really want to say it because, or I don't think I should be saying it, or I'm worried about saying it because I think that you might stop me from having surgery, or, so we can assess on the basis of knowledge that we have. We are, despite all ideas to the contrary, we can't read minds. And, we're not able to, and we don't lie detect either, because it would be hugely disrespectful of the person that we're working with. So we can think about how, as a team, we experience them, because we might experience people in different ways. And often it's the psychologist who puts together some of the pieces from other team members to reflect back with the patient, to be able to have a conversation about perhaps presenting in different ways at different times and with different people, so we can have some understanding of what else might be happening. But it's the person's responsibility of what they're able, if we've missed something in terms of mental health history or something very significant, then absolutely that's our responsibility. But in terms of disclosure, that's the person's responsibility.
And you wouldn't go cross-checking, Vanessa, on other bits of their medical records or writing to different people, lots of, just to cross-check the validity of what they're saying. You wouldn't do that, would you?
No. I think that if there are significant issues that are, if there's something that is alluded to, something that is mentioned, then I would have a conversation with a person. If they're linked in with a community mental health team or a mental health provider, would have a conversation about, is it useful for us to be able to join up so that we can help jointly support a person, particularly if their care is ongoing. So I think that there's absolutely scope for doing that, but otherwise our role is not to be a detective.
Oh, absolutely, understand it. Casey, do you want to add to that, and any thoughts on that, please? Thank you.
We do use a different approach. It sounds like in our practice, in that we always consult with outside mental health providers that our patients are working with, and not to be, again, gatekeeper, but we do know that patients, per research, underreport in the psychological evaluation. That's just, kind of a known thing, and it makes sense because there's a highly desirable outcome, and sometimes we're viewed as a hurdle to that. And our outside mental health providers that our patients are seeing know those patients so much better and provide such important information about how can we best support them. So I view that as more of a supportive role as well. And as far as toxicology screens and such, I don't see that any different than wanting to get lab work done to see what someone's A1C is, rather than just relying on their report. Yeah, my diabetes is good. Like we just like to use objective data when we can, and get some collateral information when we can, to best support our patients.
Thank you, Casey. That's very clear. Thank you. And Stephanie, your thoughts on that, please?
Well, I am a medical record, I want to say detective, except I don't want to enforce this idea that we act as detectives. I'm just nosy, and I do a ton, before I see a patient, do a ton of research in their medical chart. And then, before I see them again, I look to see what's transpired in between. And if I happen upon evidence that a patient has not been honest with me in their report, I will talk to them about it. And that's more of a concern usually than whatever the thing is that they misrepresented, is the fact that they misrepresented it. And I talk to them about why, it only helps them to be honest with me, because I can't put together the plan that's best for them if I'm not well informed. But I don't go looking for validation or invalidation of what the patient has told me. I'm just trying to keep sort of informed and up to date. And again, I tend to take the perspective of, I'm going to treat what the patient is telling me as true unless proven otherwise. And document things as well. So if a patient, denies suicidality, and then it turns out that they were, had just gotten out of a psych hospitalization and didn't tell me, again, they're adults, and we can only work with the information we have, as I think everybody has said.
Thank you, Stephanie. And that's really, I think this question for me personally, I think you all three of you have done a great job for answering for me to my satisfaction. Great, thank you. One last point. A typical bariatric patient, on an average, how many times will they end up seeing a psychologist in their whole bariatric journey in your service, Stephanie?
We're actually changing that a little bit. Right now we have the initial evaluation, an individual pre-op, an individual post-op, and a group at 6 months. And then we also say to them, if they need us for anything, we can add individual visits. We're actually changing it now, where we're keeping the evaluation, of course, but the pre-op and post-op visits are done in group format, unless we think a patient needs a little bit of individual extra help. And then we would add one individual pre and one individual post, and more if needed, plus that 6-month post-op group as well. So we're changing it, but it's not the normal model of one eval to say yay or nay, and you never see the psychologist again.
It sounds like between two personal and then two group based, kind of, yeah, in a typical patient's journey.
I would say around that, yeah.
Yeah. Okay. Wonderful. Thank you. Casey, do you want to add to those numbers? What's your, in your practice, how many times a patient would see a psychologist in their journey, please?
Our protocol is, the psychological evaluation would identify what the plan is. So I would say about half of patients just see us for that one evaluation, and then does not see us again until post-op. But for And then, again, there's a small percentage that it's going to take a long time for them to get to surgery because they have one of those severe contraindications. But most, we might see them for another session or two before surgery to monitor how they did with the treatment plan that we had developed with them. And we do a 1 month and a 3 month post-op group that we just automatically schedule for everybody at the time of surgery. But then we request that they continue to follow up at the same intervals as the rest of the team in groups or individually, just per their preference. So 6 months, 12 months, year and a half, 2 years, and then annually. However, most patients end up just dropping off, as I'm sure they do with other disciplines, after those first few months, unless they have a need and then they're coming back. So again, this one's sort of hard to quantify because it's so individualized per patient.
Well, that's great, Casey. Thank you very much. Vanessa, if I may come to you in the end there, and just rough numbers in your practice. You're on mute. Vanessa, you're on mute, I think.
There we go, sorry.
Yeah.
So within the NHS practice that I've just recently left, the tier 3 and tier 4 people would have access to psychology if needed in a group format or individually, and then post-op, not routinely for everybody, but as needed. Sometimes that would be a referral back in through to the tier 3 service into the psychologist there, and sometimes it would be, depending on the time out of surgery, might be for psychology at that point. In the private practice now I'm working in, I would see everybody routinely, pre-operatively, post-operatively. I would be part of the MDT discussion in all of the patient's care, and then would see as indicated rather than routinely.
Vanessa, thank you very much. I think that's been illuminating, really. Over to you, Sama.
So I think we're just over 90 minutes now. I think we have time for one more question. I was keen, having worked in different centers, there's some units that involve a psychiatrist and some that never do. So where do psychiatrists fit in with regards to mental health and bariatric surgery, and do they have a role all the time? Perhaps Stephanie?
So there are I know of very few bariatric psychiatrists who are sort of active in the field. The ones I know are incredible and great. I think that the one place where the psychiatrist has something to contribute that the psychologist, or in the United States, a social worker, wouldn't, is the medication piece, and looking at what's the impact on weight of the medications, what's the impact of the surgery on the absorption of the medications. I actually don't know any practices in the US that have a psychiatrist embedded in them. But I communicate with patients' psychiatrists about their meds if they're having a bypass, especially if they're on extended release meds. And I think it's really helpful to have people in the field who are studying these things and who are resources for knowledge about these things. But then otherwise, I think their role would be the same as the psychologist, evaluating these psychosocial domains, helping with preparation, helping with post-op adjustment, doing the more kind of therapeutic work. Oh, and someone is just commenting that a pharmacist can be very helpful, a bariatric pharmacist. I agree. There's very few of them that I know of. And again, the ones I know of are fantastic. But absolutely, yes.
Thank you. Casey?
I don't have much to add to what Stephanie just shared. I completely agree that they're so important in terms of monitoring those medications for the reasons I talked about with the malabsorption of medications after surgery. So we rely a lot on consulting with them, but we do not have one embedded in our program.
Thank you.
I also think that patients who have not had mental health experience before find the word psychiatrist to be very frightening, and psychologist is a little bit less frightening and a little bit less stigmatizing that we automatically think you're crazy and that's why you're seeing this person.
What about the UK, Vanessa?
I think that it seems to be dependent on how services have been set up historically. So some services have psychiatrists who agree, do a fantastic job within the team, but they've been part of the process of setting that up. I think it seems that increasingly there's access to pharmacists who specialise in bariatric surgery or have a special interest, and they're incredibly helpful. And I know that we would consult with them with regards to mental health psychiatric medication if there were any concerns that we have. That would be our sort of point of reference.
Thank you very much. I think we're gonna call it a day. Thank you again, ladies, very, very much. You've been great. There's already positive feedback on the chat on how amazing the presentations are and the topics we covered. So thanks again for agreeing to participate today. And Kamal, anything you want to add before?
No, absolutely. I concur with every word you said, Osama. We're grateful to you all, Stephanie, Vanessa, and Casey. Obviously, Paul is in our thoughts. He couldn't be with us today, but obviously we'll have to organize it back again at some time in the future for him to come and speak to us as well. We're getting great feedback on social media and everywhere regarding our event. And don't forget, we record it, and it will be watched by hundreds of people on our YouTube channel as well. So thank you for your time. We are grateful, we appreciate it, and we are honored. Thank you.
Thanks, guys. Thank you very much.
Bye-bye, everybody. Have a good day, or whatever is left of your Sunday.